Targeted therapy has been in development for many years now. We have long-term data with ibrutinib and BTK inhibitor-based therapy, which is continuous and indefinite. Maybe, Jackie, you can give us a little bit of a picture of what that entails, ibrutinib or BTK inhibitor-based therapy in the frontline setting. What can we expect? What's the progression-free survival, expectation for progression-free survival in that setting?
So there was recently an update on the long-term follow-up of RESONATE trial that led to the full approval of ibrutinib in CLL, in relapsed refractory disease. And what we're seeing over time is that with a longer time on ibrutinib, the response rates go higher, as we had seen on the phase 1 and phase 2 trials. So about 91% of the patients did achieve partial remission. Unfortunately, still complete remissions or MRD attainment of undetectable disease are still very low compared to a drug such as venetoclax, but we know that the drug is safe. Unfortunately, over time, there are discontinuations and progressions. So the discontinuations may be caused by toxicity from the drug, in particular cardiac arrhythmias. Hypertension is a big thing that may not be very well known in the community, but it happens over time and may be difficult to control with only one agent, and you might have to use a couple more agents. Additionally, after 44 months on follow-up, about 46% of the patients are still taking the drug, so meaning a lot of the patients either progress or discontinue. And usually the people that do progress are the patients that we have characteristically thought of as higher risk for progression, including 17p deletion, TP53 mutation, and possibly with a combination of complex karyotype. So there's still an unmet need for these patients.
We have seen over the last year, I can count them, 4 large randomized phase 3 clinical trials with BTK inhibitor-based therapy versus a spectrum of intensity for chemoimmunotherapy, chlorambucil-based, bendamustine-based, and FCR. All of those trials have shown improvement in progression-free survival with the BTK inhibitor-based therapy with continuous and indefinite treatment. 3 of the 4 were with ibrutinib. Recently, there was a trial that was reported actually at this ASH 2019, which is referred to as the Elevate-TN trial with acalabrutinib, another irreversible inhibitor. Maybe, Shuo, you can sort of give us some insights on the use of different BTK inhibitors now that we have two approved drugs in the frontline setting and in the relapse setting, and how you sort of think about those 2 agents and select for any particular patient which one you'll use.
Right. So as well know, the ibrutinib has been compared to conventional immunochemotherapy in several very large randomized phase 3 clinical trials, and has a very established record of efficacy, superior progression-free survival compared to conventional immunochemotherapy. So for example, the ECOG 1912 study was comparing ibrutinib plus rituximab to the FCR in the younger fitting group of CLL patients as a frontline treatment. And so that has demonstrated superior progression-free survival as well as some overall survival benefit, even though that's small. The ALIGN study was studying the older patient population, comparing ibrutinib. There are 3-arm studies. One arm is ibrutinib alone versus ibrutinib plus rituximab versus bendamustine plus rituximab. So that's in older, relatively fit population of patients. So for those population patients, both ibrutinib and ibrutinib plus rituximab seem to be superior to bendamustine rituximab in terms of progression-free survival. In another study, the Illuminate study that combines obinutuzumab with ibrutinib, comparing to obinutuzumab plus chlorambucil. So those are for elderly patients with comorbidities, unfit medical condition, and impaired renal functions. So for those group of patients, it also demonstrated that the ibrutinib obinutuzumab combination is superior to the chlorambucil obinutuzumab combination in progression-free survival. So this 3 very large randomized clinical trial has definitely established ibrutinib as a frontline treatment to be superior to our previous standard of care for all patient, all comers. But as Jackie previously mentioned, that for a subgroup of patients, when you compare the IGVH mutated patients who do not have the high-risk features, those patients in some of those trials actually have pretty similar progression-free survival. So in those group of patients, immunochemotherapy is an option that has similar clinical outcome. But if you think about the toxicity profile, I think you have to take that into consideration as well when you're choosing the therapy.